Welcome to the InfoMullet YouTube channel. If you enjoy this content, please like or share. And if you'd like to support the InfoMullet by becoming a mulleteer, visit us on Patreon. We appreciate your support. Starting out with COVID-19, one of the things we talked about in December, we had an InfoMullet article. It's called The Strategic Risk of COVID-19. And I wanted to kind of set the context of what we mean by strategic risk. And I used this graphic in that article. Now, all of our COVID-19 articles now are being authored. Well, most of them, especially the recent ones, are authored by Science Decoded. So there's a Facebook page out there. This is an actual epidemiologist, virologist who works in a lab with COVID-19, is deep in the hands-on activities with vaccine and viruses. So he's Science Decoded is writing these articles. It gives a great technical perspective. I don't want you to think I'm the expert here to this level of detail. But these articles kind of give us down in the details. And what is displayed here is like the tactical risk versus the strategic risk. So on the left side, it's a picture of D-Day. This is the invasion in Normandy that begins the final offensive, pushing in through France and into Germany to defeat the Nazi threat. Now, when I say tactical, that's not diminishing everything that's going on in that picture in Normandy. You got to land all the boats. You got to have your strategy. We went through North Africa first, then we took out Italy. So there's a grand strategy here. But when I say tactical risk, what I mean is everything on the left, all the Normandy invasions, all the logistics, the army movements, the successful campaigns would be compromised if the strategic risk on the right materialized. And the strategic risk in World War II was that the Germans developed the atomic bomb in numbers before we did. I mean, counterfactual is that Germany gets 4 to 5 atomic bombs and can use them before we reach Berlin. Totally different outcome to the World War II. And in COVID-19, the tactical risk is everything we've been trying to do that I've been tracking on pandemic response. Our policies for masking, our ability to contact, trace, test for positive cases, isolate those cases, take care of people, manage the numbers, and we haven't done well on the tactical risk whatsoever. It's been a really unfortunate how poorly we've done on the tactical risk. So we haven't done well. And the reason why it's a tactical risk is the strategic risk is that while we're focusing on all this, COVID-19 mutates like an atomic bomb to a version of COVID-19 a variant that is now defeating the vaccines we've been working on. The only strategy that works in a pandemic like this, you develop vaccines, you deploy them widely, you reach herd immunity through vaccination, and then you defeat it. But the strategic risk is that COVID-19 mutates before we get there. And I'm sorry to say, well, we've hit that point. So let's walk through some of the technical stuff here. What do we mean by mutations and variations? So assume that there's a dartboard in like the world's biggest bar or a conceptual bar. There's a dartboard hanging on the wall, and COVID-19 is some drunk, blindfolded guy throwing darts, right? What this represents is the dartboard is the risk area for these strategic risks to begin manifesting. And the darts are every mutation that happens with COVID-19. Now let's go through some terms. A mutation in COVID-19 is a change in the genetic code of an organism or the virus from what is the standard. So the original wild form of COVID-19 SARS-CoV-2 has a form. A mutation just means it changed. And every particle in your body, in anyone infected by COVID, could go through mutation. That's just a random chance that happens. So these mutations are like darts. And if you think of the numbers, inside any one person is probably millions of COVID-19 particles. So each of these is a potential dart to mutate. And then you talk about hundreds of thousands or millions of people getting infected, and the course of those infections over time, that's billions upon billions of darts that you just handed to this drunk, blindfolded dart thrower. Now, he's not throwing with any accuracy, he's just throwing a lot of darts. And what you get is some of those darts are going to hit the dartboard board. And what these different words, if it hits the board at all, right, that's an isolate. An isolate is a virus with a unique, unobserved genetic code that's a unique pattern. It's different from the original, but it's no points, right? It's on the board, but it's no points. A variant is a viral isolate that is observed, and it's got one or specific mutations that make it more transmissible, more virulent, or both. So a lot of these things that have come out that we've heard about are variants. They still are affected by the vaccines we've created, but they're more viral. They can catch people more. It's easier to pass it on. They may be more virulent or lethal, that when you get it, you suffer more. If one of those darts hits that bullseye, though, that's a viral strain. A viral strain is an isolate that has a substantially different pattern of immune reactions to other patients. That means that the vaccines that we deploy, which are specifically designed to trigger the immune response, it no longer is effective at all, or it's reduced effectiveness. Now, you throw these darts in the billions of numbers, eventually one of them is going to hit that bullseye. And what happens when they hit the bullseye? You've got these. These are some of the detailed names. I'm going to go over these in a little bit clearer here. These are the detailed names of the variants that have emerged in COVID-19 over the last 6 months. And you can see a bunch of them are no points scored. Some of them have points, but a few have hit the bullseye. And when you hit the bullseye, COVID-19 wins the race for the bomb. So we have a situation right now where it's as if Germany got the bomb before we did, because we have now a variant, a new strain that has shown the ability to defeat current vaccines, and it is spreading. Now, I want to put this in context, and we'll explain this. This isn't like we've lost World War II, abandon all hope, ye who enter here, but it is a serious risk. So the strategic risk we talked about in December, congratulations, world. We've screwed it up enough. We've met it in February. And what these nuclear races, these are some of the variants that came out. Think of these like different countries racing for the bomb during World War II. We know the Soviets were working on it. We were working on it. Germany was working on it. You know, the 614 mutation, this is really the granddaddy of all the subsequent mutations, or we suspect it is. It came out in the summer of 2020. It's slightly more contagious, right? That's a variant. It's more contagious, but the vaccine still works against it. But because we didn't take COVID seriously and we didn't stop it, people got more and more infected. We handed more darts to that dart player who we just gave him billions of more darts, and boy, did he start throwing them. The fall winter wave 2 spike infected so many more people that it was only a matter of time before some of those darts started hitting the board. Now, we had a near miss, the cluster 5 FVI spike in fall of 2020. For those who watched the Infomullet, Denmark, its entire mink population, there was a crossover mutation that went from humans to minks. They have a large mink farming industry there. They had to cull the entire mink farming industry, which is no small matter. This is a big industry in Denmark. They killed every single mink they had, and that mutation was made extinct. I mean, that's what you want to have with a mutation that's dangerous. It's extinct. Bad news for the minks, but they contained it. However, B117, this one is the one you've heard about associated with the United Kingdom, although it's broader than that. This one was identified in the fall winter of 2020. It's substantially more contagious. I'll show here in a little bit the numbers. You can see how much more contagious this one is than the previous. It's still effective for our current vaccines, and this was the basis when we wrote that article, the tactical versus strategic risk. It was about B117. Well, here comes along B11351, December of 2020. This is substantially more contagious and reduces some of the vaccines. Congratulations, this is the bomb. B1351 is the atomic bomb. COVID has it, we don't. We lost the race to the bomb. Now, doesn't mean it's worldwide yet. We'll go over into the details yet, but this is what's driving the South Africa spike where it was first detected. They do a lot of sequencing there, so they caught it there first. We don't know if it originated there. Doesn't really matter. You have, again, we've handed the drunk billions of darts, and some of them are going to hit. So where it originates is less of a concern than that we gave them so many darts that it originated. Then B11248, this is at January of 2020. Just in the last month now, this is one that has been attributed to spikes in Brazil and Japan. It was first sequenced from a traveler coming from Brazil to Japan. It's similar to B1351, which means it's more contagious and could reduce some of the efficacy of the vaccine. So what are we talking about when we talk about what does it mean when one of these gets the bomb, right? Well, so the B1135, the B11, let me get this right here. The B117 is the United Kingdom one. The B11351 is the one that was identified in South Africa. So this one, in South Africa, they're mainly using AstraZeneca and Novavax. These are two vaccines. We're not using them here in the US. We're using Moderna and Pfizer. This thing took the Novavax efficacy and dropped it from an 80 to 85, 90%. It dropped it down to 50 to 60%. What that means is when you vaccinate 100 people, instead of 95 hang immunity or 85, now only half have it. And it's basically ineffective at that point. You don't know who's really got immunity. It's not like you can really test it easily. So you vaccinate 100 people, but only half of them are good. It's an ineffective vaccine. AstraZeneca, they've halted the use of AstraZeneca in South Africa because of the risks of this virus that is now spreading there, this variant that is spreading. There's a new strain, and it appears to diminish the effectiveness. Now, unfortunately, it's not just these two vaccines that B1135 has reduced. It does appear to reduce the Pfizer and Moderna vaccines that we are currently using, not down to half, but by some percentage point, which is still being determined out by research. This is so serious that Moderna has announced they are working on boosters to be able to you get the vaccine from Moderna, then you go back and get a booster, and it should help against this variant strain that's spreading. That's a whole nother this is why the strategic risk is you get the bomb. It's hard enough to vaccinate and get herd immunity in 330 million people in the US with everything that's going on. It's a logistical nightmare. Now you got to go back and get a booster, a third visit. This is really, really what's coming difficult. And these mutations aren't over. Just because COVID-19 got the bomb now, it doesn't mean it's done picking up bombs. So let me pause here, check real quick for questions, and then I'll go into sort of some of the more details of how this happens. Don't see any questions right now related to this. So if you got questions, go ahead and add them. No pun there, Adam Bomb. Add them to the Facebook Live. But so what particularly, like, we use this analogy of handing billions of darts to the blindfolded drunk bar player, and he hit a bullseye. Well, of course, causally, that's an analogy. Causally, the sheer causal mechanism that causes the most basic one is every person who gets infected has millions of potential particles in them, COVID particles. Every single one of those particles has a chance to mutate. Every single mutation has a chance to mutate into an isolate, a variant, or a strain. And those are low probabilities. But as we got more and more people infected, anyone who plays a game, you start adding more and more dice to the pool, no matter how rare that probability is for a critical failure, it's going to come up unless it's me playing, and then it comes up all the time. But there's also been some specific things that have come up, what we call perfect storm circumstances. And this is research that's only come out. You can find it in the links on the InfoMullet article. There are certain patients who get COVID-19, and because they have a pre-existing immunocompromisation, their immune system's compromised for some existing reason, they do not kick COVID-19. It lives in them, and it's not that they have it dormant. They have an active, ongoing infection for months, and we give them the best medical care we can, which we should. And they can survive for months. They may die eventually, but during that time in their body, the COVID-19 is continuously mutating within the same host. This is a very unusual circumstance for a virus to be a continuous infection like this for months at a time. So those millions of particles in there are now in a multi-stage, and instead of being a random roll of the dice, it's like you're rolling the same set of dice and continuing to add on to it each time when it's in the same hoster. They're building off one another. Those mutations that are coming are combining and that creates the perfect storm conditions. Now, this isn't to say we should stop supporting immunocompromised patients, but we need to be very careful about how they're isolated, because what's happened is it's believed that some of these perfect storm circumstances, the virus then transmitted from the infected patient who was infected for months at a time. You have exhausted workers, you have PPP struggles, you have a crush of patients. It escapes and transmits and re-enters the community, and that's where you get some of these variant and strains. Some of it may just be lucky dart throwing, but where does that leave us in terms of where are we facing this? Yeah, I'm seeing some good comments here. We'll get to them in a second when we talk about how we contain the bomb. So let me share here. So this is a map right now of where the virus has spread for B117. Again, this is the one that was identified in the UK, caused a large spike in the UK. It's not defeating the vaccine. It's simply far more contagious. You can see it's really prevalent. And this is not a per capita. This is just a number of established cases. We don't have a lot of sequencing capacity. So this isn't like, you know, it could be much more widespread, but we found them in this. And we find a cluster in California and Florida, both of which have had huge spikes in coronavirus. Part of it may be this B117 variant that's existing there. The B1351, right now, these charts are as of this morning. So there's the CDC websites, if you want to check yourself, the links are below. The B1351 has not been seen as widely, but it has showed up. Texas, California, the mid-Atlantic. So the bomb is here. We don't know to what extent it's going to spread, but we have found evidence of it. And that means that this, you know, if this continues to, with the current outbreak, if it continues to spread and gain traction, we may have shot ourselves in the foot with our vaccine as we drive that. So let's take a look now on where we're at in the, here we go. So I'm going to show some charts here which show the, there we go. So for those who have seen this before, all right. So this is our Waldron data, COVID cases. This is cases per million. And I picked a couple countries here. You've got United States, United Kingdom, Germany, South Africa, Canada, and Sweden. You can begin if you zoom past the time here. Again, these are 7-day rolling average confirmed cases per million people. So it's all population adjusted. You can see here the massive spikes as we go in here, let's say December, right? Let's move forward. So we're just looking at, this was wave 2 was accelerating, and you can see this United Kingdom, it actually drops going into December 6th, and then this is that spike that's attributed to B117. And this is, it was kind of detected here around Christmas is when they detected it, massive spike. Same thing with South Africa. You can see South Africa, much lower spike, and this is being attributed to the B1351, massive spike, drops, almost in the same pattern in time. In fact, a lot of these are, you know, it's because of the Christmas holiday break that these 7-day rolling averages, because it's averaging, it looks like they all happen at the same time, but it's because the infections that occurred during Christmas break were being recognized here, and then it begins tapering off, and you see the decline. Now, this is good. The decline is good. Well, Sweden's struggling. Sweden's kind of flatline. But again, when we look at waves, we don't want to just look at the number of cases per capita, but we can look at the biweekly change. And what you see here is on the percent here, this is the percent of biweekly change. A positive percent means accelerating, negative percent means declining or decelerating. So to when we look at this, this gives you a heads up, and you can see here this spike, and it's hard to read because you can see here in Sweden, Sweden and the United States and all that drive some really hard numbers. So let's zoom it in more, get it just in that last month here. You can see again the United Kingdom spike and the South Africa spike in terms of percent of changes. Massive spikes, way more than this is the manifestation of the B117 and the B1351. Just purely the contagion, the contagiousness of this is demonstrated by these massive increases. And so you can see we're declining. Here's our post-Christmas spike. Congratulations, everyone. Way to screw it up. We get a post-Christmas strike. And now everyone is declining again, except for poor Sweden. Alas, poor Sweden. I don't, you know, who knows what they're doing now, but they've had a minor increase. But again, this is all below zero, so it's negative, it's declining. This doesn't mean we're out of the woods, because if you look at this as just a cumulative, it becomes, oh, excuse me, 7-day rolling average. Here we go. You can see here the spikes. You can see if you go back and look over time, this is the more traditional view that people may be more familiar with, which is just a pure number of cases, 7-day rolling average. You can see here wave 1, and then it drops, and then we get wave 1.5, and then this is where South Africa gets its first wave. Then we drop, everyone drops, then wave 2 hits. And you can see that even though we're dropping, this is important, even though we're dropping so significantly, we were so high to begin with, we're still higher. We're at 85,000 cases on average per over 7-day average now. That's higher than the peak over the summer, which was 65,000 cases a day. So the lull of wave 2 is still higher than the peak of wave 1.5 and much higher than the peak of wave 1. Now you see this also in confirmed deaths. Confirmed deaths, obviously, first wave, no one was ready for it, so it was a little bit higher here than in wave 1.5. And then you get this spike here in the US. Again, we are just now dropping 2,100 deaths on a 7-day rolling average versus our peak in March. So we're just now dropping beneath the peak of the first wave. And, this is just total numbers. If you do it population adjusted, it shows a little bit different. It shows how the United Kingdom and South Africa, because of that spike, what the spike does is, even if the virus itself is not more virulent, it's not more lethal in nature, if it's more contagious, that has a feedback effect. More people get it, more people go to the hospital, more resources are taken up in the hospital, they have less spare capacity. When they run out of capacity, I don't care even if the virus is the same virulence as it was at the beginning, if you go in with a severe or critical case and they run out of hospital capacity, your chances of dying go way up. So that's why you see the death spikes here. Here is same data. So that is where we're at. And so we have a possibility to cut this off as we have a declining wave 2. But to do that, it's kind of like containing a bomb. The bomb's already out, right? It's loose in the environment. Well, how do we contain it? First of all, you have to reduce total daily infections. And it's not just reducing it to 60,000 a day. Yeah, congrats, only 60,000 a day times million of particles in each person. That's not going to do it. You really need to get numbers down to near zero. You're talking New Zealand level numbers, or at least South Korea numbers, which are, a couple hundred a day or a couple dozen a day. We have to do that. We don't get out of this by ignoring that, because think of this: every time these vaccines that we create them and we say, we'll go back to normal, we have a vaccine. Well, COVID could make a new bomb, right? As long as it goes around in us, it's going to stick with us. So we have to get those down to the point where it stops. We got to stop giving darts to the dart player, right? That's the first thing. The second is we need to do load balancing of healthcare services. Now, I've talked about this for months, going back to the beginning. We were originally talking between the states, but we can't just think about this parochially as our country and their country, or this country and that country. The pandemic is worldwide, and as long as COVID-19 exists anywhere, its risk is everywhere. So we could be doing great ourselves, not that we are, but let's say we're doing great, and someplace in Europe or Asia or South America struggles, and a new variant crops up there that defeats our vaccine and bypasses it. Well, we're not immune to that. That's going to come back and get us. So we have to load balance healthcare services internationally. We didn't win World War II by going at it alone. We had an international cooperation between major powers. We coordinated. We did it. Anytime you've got a truly global crisis, you have to have better international coordination than what we've seen. You can't do it without. We need to make sure that we're minimizing those perfect storm conditions, which means that we need to have, for those who are immunocompromised, we need to identify them quickly, give them all the support they need and the medical care they need, but also make sure that the transmission out of that perfect storm isn't introducing new variants. We obviously continue developing and updating vaccines, but that only goes so far. You can't, that's going to be, everyone's going to say, well, we got a new vaccine and we got a new booster. It's logistically complicated. Pretty soon, you think you have COVID fatigue? Wait until we start having vaccine fatigue. Oh, I got my shot a year ago and I don't want to get a booster because it's blah, blah, blah. Well, you can't keep changing the vaccine and expecting that not to happen. So yes, getting new vaccines, getting boosters, that's good. But we need to improve our testing, contact tracing, and when we get down to that, so that we're not allowing these new outbreaks to happen. And part of that is sequencing. We haven't talked about sequencing a whole lot because it's all been about testing, find who's positive. But sequencing is like, what particular variant or strain of COVID does a person have? One reason B.1.351 was discovered in South Africa is they sequence a lot more of their samples than we do. So it may have originated here, it may have originated in the UK. We don't know. The place that it was first identified was in South Africa. So we need to sequence a lot more of our samples to find out what variants are going around in the country so we can better prepare and plan. We need to improve our, public health interventions. Someone was talking about masking, or Charles was talking about masking earlier. It includes, but not as limited to, mask mandates, capacity limits, venue closures, all these things, public school closures. People want to get back to normal, but the need to get back to normal has meant ignoring the war we were fighting and allowing the enemy to win. You cannot win a war by ignoring it and then thinking it will just go away and you'll be back to normal. We have to treat this like the serious threat it is, and put in place the measures and find innovative ways to make sure that we're not compromising other healthcare outcomes by just using ham-fisted things that we maybe, Germany has been doing these closures for now. They've got a lot more sophisticated ways of balancing public schools. Canada's schools are open, but a lot of other things are shut down because they're balancing those R factors. We in the US, we want our bars, we want our schools, we want our music venues, we want to go outside, we want to ignore this. Well, if you don't make trade-off choices, you're not going to get ahead. You got to figure out what your priorities are. So if we want to open schools, that means other things have to be shut down as we're playing with that R factor value and getting it beneath that R1 of replication. And then again, we're going to have to get the sequencing under control. So let me pause here and see if there's a question. Yeah, it would be great if there was an easier way to deploy the vaccine. Mike Morrison's putting a good point here. Like you could do it, you could spray it for mosquitoes, or you could put it in the water like fluoride. I would love to think that maybe Science Decoded can take, if that's even a technology on the horizon. I don't think it is. Sounds new to me. Yeah, people are comparing the U.S. to Sweden, saying leave Sweden alone. Ed's saying, hey, teacher, leave those Swedes alone. Great Twisted Sister reference there. So the fall right now, the part of the way to collapse is, I wouldn't say it's like brilliant. Like, there's things in war that you could say, hey, look at Patton. He knows what he's doing. He's a successful general. He's commanding. He's doing successful things. I don't think we can credit the collapse of wave 2 to that. I think we can credit it to the lack of major events like Thanksgiving, like Christmas, where everyone goes out and travels and gets around. But guess what's coming up? People have mentioned other things. Hey, look, it's oh, I'm getting corrected. It was Pink Floyd, not Twisted Sister. Well, Twisted Sister's better than Pink Floyd on any day of the week. Just, take it for what it is. I think I just gained a lot more hated, and I can feel my reviews going down. What was it, Twisted Sister? Didn't they say something about leave those kids alone or something? Or, we're not going to take it? I don't know. Something with kids and things. Great. I do thousands of hours of Infomullet references, nail every single one. I screw up 2 bands, and now the comments are going like you wouldn't believe. So if I could but let's switch to something I know as opposed to pop music from the 70s. If there's any more questions on COVID-19, again, we've got to take it seriously with the bomb going on. It's not going to get back to normal. My forecast for 2021 is we're not under new normal until 2022 at least, and this seems to confirm that. So, question. Is it possible that a variant could evolve that could affect children the way it currently affects adults now? That's a better question for Science Decoded. I would certainly say it's within the realm of possibility. These are all characteristics that are basically like values, and the current value of COVID may have less impact on kids in the short term, although we're still doing research on the long-term impacts. But one of those value changes, it could impact kids. This is why I call it the strategic risk. Everything we do is based on what we know of the virus. And since it's a novel virus, we started out not knowing much. We've learned a lot, but if we allow it to mutate into a strain that defeats our vaccines and has other characteristics of contagiousness or virulence, some of those may be more harmful to kids. That's I think it's a real risk, but I hope Science Decoded to answer that. Yeah, Science Decoded has now arrived. Give some love to Science Decoded. He has arrived on it. We're just ending up the COVID-19. Valeria is asking more info on new normal. So the new normal is, I think we continue to roll out the vaccine. So vaccine deployment is accelerating everywhere, but the problem is the vaccines that we're deploying are built off the wild or original COVID-19 strain. We think that vaccine is effective against every other variant, B117, all those other things that are more contagious. The vaccine is still good for that. But B1351 and what was that other one? B11248. Those ones, the B1351, we see that it's knocked back the Novavax and the AstraZeneca vaccine and has reduced the efficacy of the Moderna and Pfizer. The research is still out yet. Even if there was none of these variants, we would have struggled to get back to normal in 2021 just because of the logistical challenge of these variants or the vaccines. Adding in these new variants, I think we're looking at mid 2022, maybe even late 2022. I mean, this is one of the things that we take for granted, the privilege that we haven't been faced in our lifetimes with the Terminators type situation. It cannot be negotiated with. It cannot be dealt with. You have to just beat it. And past generations have faced these. They have faced sequences of pandemics that show up every single year and cull the population. We may be living with that for a very long time if we don't get our act together. Now, over time, people will begin to realize this is much more like smallpox or polio. It's not just a flash in the pan, and hopefully you'll see that adoption, but it could take a lot longer if we don't get our act together. And again, we can't just beat it in the United States or Canada or Germany. We have to beat it worldwide. These variants can occur anywhere, and if they occur anywhere, they can impact everywhere. So the challenge we face now is we have to have global coordination to reduce the infections, put in a vaccine, get it in place, have a vaccine uptake enough that creates that vaccine-created herd immunity, and then we'll be able to get back to new normal. Oh, and science is adding a new one to the list. Last night, B1525 observed also in England. Mini Spanish flu in England right now due to the quality of genomic surveillance in the UK. So, yeah, wow. So that was good news. Thanks, Science Decoded. Thanks for showing up. Give us another piece of bad news. Looks like there's a new variant, B1525, cropping up in England. And again, these things are replicating off themselves. So thanks for watching the video. Hope you enjoyed it. If you'd like to follow the InfoMullet, visit us on Facebook or Twitter. And if you'd like notifications when we post new video content, click on the red subscribe button below the video. If you've ever wanted to become a muleteer and support the InfoMullet, visit us on Patreon. We appreciate the support.